I welcome everyone. Welcome. I'll just give us maybe a few seconds so that everyone comes into the room. Welcome to this webinar. It is so good to have you all with us. Give everyone just a few seconds and then we will proceed. All right. I'm Ofni Lamont, and I'm officially welcoming everyone to this webinar that is being hosted by the GC Foster College of Physical Education and Sports in association with the Jamaica Association of Sports Medicine, and we want to wholeheartedly welcome you on today. Today's discussion and session is going to be extremely informative, I'm sure. And at this time, I'm going to invite Mrs. Denton Sadler, who is the nurse at GC Foster College, to open us out with prayer, and then I will return and introduce our moderator who will then guide the process thereon. Mrs. Sadler.
All right, good afternoon, everybody. I invite you to assume an attitude of prayer while I pray. Let us pray then. Loving Heavenly Father, we are so grateful to you for the opportunity to just be alive. Because, Lord, we realize that we're living in a time when death has become common and you have spared our lives. We thank you so much for this gift. And Father, we thank you for the persons who were able to organize this webinar. And we ask, Lord, that as we venture into these discussions, that they will be fruitful. And Lord, that they will be fruitful not only for GC Foster and the attendees who are here, but for Jamaica at large and for all our athletes, because Lord, we know that even they are affected by what is happening today. We thank you for those who are able to join us, and we ask that you continue to be with us right throughout this series. In Jesus' name, amen.
Amen.
Amen. And so at this time, I want to introduce to us our moderator for the webinar. He is Mr. Paul Beckford, and he is currently the Vice Principal of Administration at the GC Foster College, and he will be guiding the proceedings. He'll be giving some preliminary information as it relates to the question and answer section, and he will also introduce each speaker. So I'm going to hand over to Mr. Beckford at this time.
Thank you very much, Mr. Lamont, and good evening to our viewers, listeners, panelists, and everyone else who is to the hearing of my voice. Just want to welcome you to this webinar that is GC Foster College of Physical Education and Sport in association with the Jamaica Association of Sports Medicine, presenting to you this webinar, COVID-19 and the athlete returning to sport. And I would assume that everyone would have been looking deeply into this topic because this is something that we have been anticipating over a period of time. How will the athlete adjust and adapt in a time like this, and looking forward to returning to sports? And through this collaboration with GC Foster and the Jamaica Sports Medicine Association, we should be able to provide you with enough guidance or information as it relates to the issue. Now, as Mr. Lamont alluded earlier on, as the speakers make their presentation, you are advised to make note of the questions that you would have wanted to ask. And I'm going to be handing over that segment to Mr. Lamont once more while he guides that process. And what we'll do after each presenter concludes his or her topic, then you are allowed to ask questions where you can type the questions in the chat area. Mr. Lamont will make note of the questions and he will read the questions in order for the presenters to respond accordingly. Ladies and gentlemen, before we begin, I want to apologize for the absence of one of our panelists, Mr. Gibbs Williams, who was called to regional duties. You know, he's a national fitness trainer for the cricket team, and he was called suddenly for some duties. So unavoidably, he will be absent from this presentation this evening. So we still have with us Dr. David Hanson and Dr. Kevin Jones. We also have Dr. Joan Rattery along with the team. So ladies and gentlemen, I want to, at this moment, introduce to you the first of our speakers, and that is Dr. David Hanson. Dr. Hanson was born in the town of Mandeville in the parish of Manchester, Jamaica, with 5 girls already in the home. His parents were just overjoyed to finally welcome a boy into the home. When he was born, they tried again and got his brother a little over a year later. After that, he decided to confine being fruitful and multiplying to their ministry as a clergyman and wife, addressing the needs of their congregants and that of one of 2 cousins that were already part of the Hanson's household. David grew up in the little village of Hopewell in the parish of Hanover, nestled by the sea between the exclusive Trial and Roundhill hotels. After 14 years of distinguished ministry there, his parents moved back to Mandeville, where they continued ministry in the Missionary Church Association. Having earned a scholarship via the Common Entrance exams, he attended Cornwall College in Montego Bay for the first 4 years of high school. Then in 1977, transferred to Manchester High. He eventually became a deputy head boy and represented the school in football. Having completed 6th form, he went to a college career at Hardwork University, aka College of the Ozarks, Point Lookout, Missouri, USA. Here, all students work their way through college under adult supervisory and academic staff, and student loans are discouraged. He did his freshman year working in a hotel and cafeteria, then completed college as a lab assistant in the biology chemistry departments. While there, he occupied several leadership positions, represented the Foreign Students Association in soccer, was the recipient of many awards, and was named the College Academic Dean's List and the National Dean's List from his sophomore year to his senior. He was also named in the Who's Who in America colleges and universities in 1984 to 95. He graduated cum laude in 1986. Having completed his internship between the University Hospital of the West Indies and Mandeville Hospital, he went on to work as a junior resident in general surgery at the Mandeville Hospital, then spent 14 years in Junction, St. Elizabeth as a general practitioner. In 2008, he moved back to Mandeville to continue practicing at the Ward Mount Medical Center and later worked as a medical officer at the Manchester Health Department, an emergency room doctor at the Mandeville Medical Hospital, and then resident in the ENT department in 2014, where he completed the Masters in Sports Medicine at the University Hospital of the West Indies in February of this year. He started working with the United States Peace Corps as a Peace Corps medical officer. He is currently the vice president of the Central Chapter of the Jamaica Association of Sports Medicine and has always been heavily involved in sports. Since his teens, he has been a regular Blue Mountain hiker. In college, he represented the Foreign Students Association in soccer, playing against other colleges, while being involved in swimming, bodybuilding, racquetball, lawn tennis, and the wilderness activities club on campus. He continued some of these activities throughout medical school, and from 1993 to 2013, provided medical care for the various teams at Manchester High. He also provided care for the Las Perfectas Football Club and was a member of their Masters team. He has traveled with both senior and junior national teams and is a regular care provider at the National Stadium for medical and major events. He's married and has 2 children. He enjoys sports and outdoor activities, as well as doing repairs to his home, office, and vehicles. Ladies and gentlemen, I use this opportunity to present to you Dr. David Hanson.
Okay, good afternoon, everyone. I want to congratulate GC Foster and the Jamaica Association of Sports Medicine on putting on this very good webinar, which I hope will provide some enlightenment both on our part as people involved in sports, as well as on the part of those who may be involved in the Ministry of Health, so that when we have dialogue, we understand each other better. Can you bring up the screen for me, Mr. Allen? Mr. Allen?
Oh. All right. Let me see if I can do that for you, David.
Okay. Right. Thank you.
Hold on. I think I need to put it on slide. Is that how it goes? Slideshow. That one.
Yeah.
That's full screen there, right?
Yeah. All right. So you got a very comprehensive introduction there. I really didn't expect that. But thank you. So one correction, though, I'm currently president of the Central Chapter of the Jamaica Association, Jamaica Association of Sports Medicine, and I'm also a member of the national body. All right, so we're talking about COVID-19 and the athlete today. I will start with some basic definitions. Joan, I am not, okay. So what is an athlete? An athlete is anyone who is involved in training where there's a priority about training, competition, and sports achievement. So this is a broad definition, and it is so by intention. You may have elite athletes, you may have amateur athletes, you may have professional athletes. You have young athletes, adult athletes, and master athletes. Those are people who are over 35 years of age. And you have able-bodied and those with disabilities who are still considered athletes. And then you have some who pretend to be athletes and fake it. The scrolling is a little delayed. All right, what is a virus? So it's easier to describe to you what a virus is not than to explain to you what it is. So it is not a plant, it is not an animal, it's not a bacteria, it's not a fungus. It does, however, invade any of these organisms. So any one of them may play host to a virus. Now, viruses are submicroscopic, meaning that you cannot see them with the naked eye, and you cannot see them with a light microscope. You need to have what is called an electron microscope in order to see them. So that all the images that you're seeing on TV and in the media are images captured by an electron microscope. The diameter of the SARS-CoV-2 virus is between 60 and 140 nanometers. In the strictest sense of the word, they are not considered to be live organisms in that they have no energy production or storage capacity. All the building blocks of life that they need are derived from invading a host and taking over the processes that occur in the host that they invade. All vital functions are performed by the host cell. And this is just an example. There are two general forms to what a virus looks like. So on the left, you'll have the sphere. And then on the right, you have what is called the rods or filaments. These are the two basic forms that that viruses take. And of course, we have the culprit, SARS-CoV-2, which is spherical. The reason why it is called the coronavirus, corona means crown. So instead of having a single sphere at the tip of the spike that you see on the figure 2 in the diagram, you have several small nodes around that spike at the tip of the spike, which forms something that looks like a crown. And that's why it is called the coronavirus. Does it jump species? This is something that everybody wonders where it came from. Was it bioengineered? Did it come out of China's labs? What we can say is that SARS-CoV-2 shares 96% of its genetic content with that of the RATG13 coronavirus, which is also found in a bat species. We also know that the spike receptor binding domain, that is the tip of the spike on the corona, that binds to the cell, human cells, and invade it. That part is similar to that found in the Malayan pangolin. A pangolin is simply an anteater that has an armor plates all over it. And those, I believe, were present in the market in Wuhan. So to answer your question, to this day, we are not sure. A group from the WHO and the European Union had recently visited China, and the whole intent was to try and find out what were the origins of this virus, but apparently a lot of information was not forthcoming, and they left very dissatisfied. How is it transmitted? Well, it's transmitted through air by droplets, and it's also transmitted on contaminated surfaces. And I've listed a number of different surfaces here. Surface viability. I just want you to note that the solid surfaces will accommodate the virus between a few hours to several days. And you can see metal, wood, plastics, glass, and ceramics. Paper will have it for a few minutes to 5 days. Cardboard, 24 hours or less. No research has been done on fabrics, but it is probably shorter than on hard surfaces. Next slide. What are the modes of spread? Food and takeout produce. No spread has been recorded from those. In terms of treated water, there has been no transmission noted from that as well. Viruses being carried on your shoes. A study was done in Wuhan in one of the ICUs at their hospitals, and they did detect some nucleic acid, that's the genetic material from the virus, on the shoes, but they couldn't say whether or not it was capable of transmitting infection. They also did studies on the skin and the hair. Information is not available yet, but all we know is that the common cold virus will last for hours on skin and hair. What are the clinical features of COVID-19? I've sort of been asked to limit my comments to the cardiovascular system and the respiratory system, so this will be a little focused. But remember that it is multi-systemic in how it affects the human body. You will have those who have tested positive for the virus, but they are asymptomatic. They have no complaints at all. The virus is present, but it is in stealth mode. And in fact, I have a friend who works in the isolation unit for COVID patients at Mandeville Hospital who recently told me that he was tested positive for it, but he had absolutely no symptoms. He would never have known unless they had tested him for it. So there are those people who will test positive, but they have absolutely no symptoms at all. And that's true of the majority of people who will be infected. You have mild COVID-19, and I want to point out the distinction in terminology here. So the virus's name is SARS-CoV-2. The disease that it causes is COVID-19 disease. So mild COVID-19 will manifest as vague and self-limited fatigue. You can have loss of smell, loss of taste, you may have headache, you can have upper airway congestion and sore throat or cough. And it may also cause things like nausea, vomiting, and diarrhea, but that's less common and more likely in older people. Now, moderate to severe COVID-19 will manifest with a fever. You can have chills, ague, muscle aches and pains. And one of the most common complaints is severe weakness. In terms of heart effects, cardiac refers to the heart, vascular refers to the blood vessels. So in terms of cardiac effect, you can have what is called a myopericarditis, myo meaning muscle, peri means around the heart, carditis means inflammation of the heart. And this may manifest as chest pains and tightness because it impairs the blood supply to the muscles of the heart so that when you exert yourself, the demand that is placed on the heart muscles cannot be met. It may manifest as shortness of breath and poor exercise tolerance because you have a structural insult to the muscles of the heart, so they cannot function properly as a pump. And it can also disturb the electrical system that drives the heart. So the heart is essentially an electrical pump. And if you disrupt the electrical conduction in the heart, then you can get palpitations, what we call arrhythmias. All of this can lead to dizziness because it may reduce the blood flow to the brain and consequently cause you some dizziness. In terms of blood vessels, 20 to 30% of the symptomatic patients will develop clots to the heart, and that will cause a heart attack, clots to the brain, which can cause a stroke, and clots to the lungs, which can cause a life-threatening pulmonary embolus. In terms of respiratory clinical features, 80% of the people who contract it might have mild to moderate symptoms. So like dry cough, sore throat, pneumonia, nasal congestion. It can inflame the lining of the eyes to give you a conjunctivitis. And you can also have loss of smell and taste. 14% will have it severely, and this will be due to a collection of fluid and debris filling the airways and the air sacs in the lungs and causing respiratory distress because it starts blocking the exchange of gases in the lungs. 5% of people will manifest as critical respiratory cases. And in this case, they have significant lung damage from swelling and severe inflammation, which overwhelms the capacity of the lungs to exchange oxygen for carbon dioxide. And in these people, you will need mechanical ventilation. What causes all of this? Well, the virus is known to trigger what is called a cytokine storm syndrome. Cytokines are chemical messengers that are released by your immune system when they are challenged by a foreign body, such as a bacteria or a virus or something else. Think of the hamstrings and the quads working in tandem with each other. The inflammatory response is a lot like that. You have pro-inflammatory cytokines that are released, which encourage inflammation. And then you have anti-inflammatory cytokines that are all also released at the same time. And they work in tandem to sort of regulate the immune response so that you don't have excessive response being done from the immune system. This virus is able to trigger the stem cells that give rise to red blood cells, and they release something called interferon gamma, which turbocharges the pro-inflammatory response. And this leads to an overwhelming of the anti-inflammatory balance. And so it gets out of control. And so your bronchial tree, your blood vessels, the heart, kidneys, bowels, any organ can be affected by this response. Cardiovascular injury will impair delivery of blood, and lung damage will impair delivery of oxygen to the blood. So what is the treatment? Prevention is the most important part of managing this pandemic. So personal protective equipment such as surgical mask, respiratory mask, airborne precautions, So for example, at the hospital, they have what they call negative pressure rooms that have been specially built so that when you are intubating patients, you don't have airborne spread from doing the intubation. Hand washing is very important, disinfection of surfaces and fomites. When intervention becomes necessary, high flow oxygen is one of the basic deliveries that has to be done. And that may be done by nasal cannulas. And what is used depends on how severe the respiratory distress is. So the nasal cannula is the start, and then you can progress to non-rebreather masks, so that the non-rebreather masks are the ones that don't have the bag attached, and they concentrate the oxygen. Positive pressure ventilation is not so much used unless there's a lack of nasal cannulas and the person does not need any intubation. Mechanical ventilation is what they use in the ICU, and this is used when people are in acute respiratory distress syndrome. Extracorporeal membrane oxygenation, big word, it just means a mechanical lungs. Those are usually used when you have open heart surgery, and a machine is used to put oxygen in the blood and circulate it back to the body while you're doing open heart surgery. Those are very uncommon, very expensive. You won't find them in use anywhere in the world too often. Antibiotics have a role to play because even though this may start as a viral infection, you can have a bacterial infection on top of that viral infection. So antibiotics are part of the treatment. Hydroxychloroquine has been bandied about, especially by the famous past president of the United States. All the studies that have been done at various stages of this disease have not shown any evidence to suggest that hydroxychloroquine helps at all. The antiviral medication remdesivir has also been mentioned. Thus far, there are still trials going on. The only place that is available in Jamaica really is at Cornwall Regional Hospital, and I suspect they are participating in a trial to gather evidence as to how useful it might be. Convalescent plasma, that is plasma that you get from people who have already been infected with COVID-19 and have formed antibodies, and you harvest those antibodies and use it in patients who now have the fresh infection. And that has been shown to be useful, but clinical trials are still going on about that. Corticosteroids, these are drugs like dexamethasone, have become very, very essential items in managing these patients. It is used, remember we spoke about the cytokine storm, the inflammatory storm. The corticosteroids are the anti-inflammatory medications that we use to temper that response. It is not used during the replication phase while you're incubating the virus. It is used when you have the cytokine storm going on and it's an inflammatory process. There are other vitamins that people have been encouraged to take to boost their immune systems. Vitamin C as a high dose IV medication has been contemplated, but no trials or evidence are available yet. Vitamin D helps to affect the ACE2 receptor. That's the receptor that the virus binds to, and Dr. Jones will go into that in further detail in his presentation. But it helps to reduce the cytokine chemokine storm. It helps to modulate the immune response and the renin-angiotensin system, something which Dr. Jones will mention again. And it helps to maintain the lung surface lining, which is what is damaged by this virus. But it still needs further studies. Zinc is an anti-inflammatory and antioxidant, but high doses of zinc will impair copper absorption in the bowels, and it will suppress immunity if abused. Anticoagulation is another important arm to the treatment of this condition. Anticoagulants are blood thinners. They reduce the clotting of the blood. And it is now recommended for all of those with no reason not to be on them. So contraindication is anything that says you should not take this drug because the risk of taking it is far outweighs the benefit of taking it. So in anyone who has had COVID, they haven't really stated whether it's mild, moderate, severe, but definitely in mild to moderate to severe cases and critical cases, anticoagulation is very, very important. Other treatments, respiratory physiotherapy is done while patients are in isolation, and it will be needed afterwards in convalescence and in rehabilitation. Anecdotal evidence is now available about inhalers. So we use steroid inhalers in people who have chronic obstructive airway disease or asthma. And it has been found, initially we expected that the asthmatics would be the ones to suffer most because of this condition. However, what they have found is that a lot of asthmatics have not done so badly because they were on inhaled steroids, and that has tempered the inflammatory response. So a lot of the patients who are now discharged from hospital are sent home on steroid inhalers because they have found that it has a protective aspect to it. So what about returning to sports in people who have had cardiovascular problems? What you see on the screen are some basic screening investigations and monitoring that will be needed in people who have had COVID-19 disease with cardiovascular involvement. And the basic screening would involve a resting echocardiogram, which is like an ultrasound of the heart, 24-hour Holter monitoring, which is like wearing an ECG machine for 24 hours, which takes the reading of the electrical activity in the heart. And then they download it and they will analyze it and see if there's anything irregular in the heartbeat. Exercise 12 lead ECG is recommended as being done 3 to 6 months, less than 3 to 6 months after illness. And it's recommended that you monitor the serum markers of heart injury. So that would be the troponin, highly specific cardiac troponin, and the BNP, which is an indicator for cardiac failure. Advanced testing is used at times, and we'll go through an algorithm where that comes into play. But cardiac magnetic resonance imaging and extended duration ambulatory rhythm monitoring. Big words. Cardiac magnetic resonance imaging is a radiological technique, and the extended duration ambulatory rhythm monitoring is basically like the 24-hour Holter monitoring, but you wear the machine for longer. What you're looking for when you do these tests are three things. You must have a return to normal ventricular systolic function. Systole is when the heart pumps blood out of the heart. So you're looking for normal function there. It tells you that the pump is functioning properly. You're looking for correction of the blood test results, which will say there's no more cardiac heart injury and there's no more heart failure. And then you look at the electrical activity of the heart, and all the arrhythmias should be resolved when you do the Holter monitoring and the exercise 12 lead ECG. Next slide. Now, as you can tell, these are not inexpensive tests, and there are some barriers to everybody accessing this. So there may be geographical barriers, there may be social background barriers in terms of costs, demographics, and the logistics and cost to cover the sheer numbers of cardiac screening that you would have to do in this country or even in the USA would be prohibitive. So there are some barriers to doing all of this. Next. All right, so this is an algorithm that we'll just run through quickly. I know it looks very complex. This was put out by the American College of Cardiology sports in the sports and exercise segment of the American College of Cardiology. And we'll just run through it quickly. So in people who have never had COVID, they can return to play, no questions asked. For those who have tested positive, who are less than 15 years old, so this should interest some of the coaches, they may be those who are asymptomatic, and all they need to do is rest. They should have no exercise for 10 days from the positive test. They can return to play without testing if there's no history to suggest that they should be tested. Okay? In those who have had mild symptoms, they should rest, have no exercise for 10 days from symptom onset, and they must have full resolution of the symptoms. So they must have gone at least 24 hours without a fever, and they must have gone 3 days, I believe, without cough and some of the other symptoms that are common to this disease. They can be considered on an individual basis, but they can return to play usually. Return to play meaning that they must be under the guidance of a certified trainer, and they have to do it gradually, slowly and gradually. All right? In those with moderate symptoms, with or without cardiovascular symptoms, who have never been hospitalized, they should do self-isolation per the CDC guidelines, and they should follow up with a general pediatrician after resolution of the symptoms. They now need to do 10 to 14 days of convalescence after the symptoms have settled and before thinking of returning to play. With these patients, you have to consider formal cardiovascular risk stratification by doing the tests I mentioned before, the ECG, the blood test, and the echocardiogram. In all of this, they can return to play if they are fine. If, however, they run into fresh symptoms, and that holds true for severe symptoms as well. People with severe symptoms who have been hospitalized, they follow up with the general pediatrician. They do the convalescent period before thinking of returning to play. And they should be subject to some form of cardiovascular risk stratification. They can return to play with graded resumption of activity, but if any member of these groups run into symptoms while they are doing gradual return to play, then they need to have they need to be investigated further with the ECG, the blood test, and the echocardiogram. In those who are over age 15, they follow the guidelines for adults and they can return to play. And we look at the adult algorithm after this. But if they run into problems in their gradual return to activity, they also will need to have clinical evaluation and do further testing with the ECG, the blood test, and the echocardiogram. Now, some of these patients in this age group will have a syndrome that they call multisystem inflammatory syndrome. And it is a syndrome that tends to affect teenagers. And those who have that will have to be admitted and investigated in hospital. Now here, this is where the cardiac magnetic resonance imaging comes into play. This is used to assess whether or not you have injury to the heart, and it will pick up things like swelling of the heart and cardiac injury. If that CMR, cardiac magnetic resonance, is okay, then they can follow the return to play guidelines. However, if it is not okay, then they go on to do the further testing which we listed before. So they will have to do the exercise testing and extended ambulatory rhythm monitoring. In all of this, you have to consider other causes of their symptoms as well. So are they anemic? Do they have some other inflammatory process going on? So do they have any liver function problems? So in all of this, we need to still have in the back of our minds that there can be other problems that are causing their symptoms. All right, next slide. Right, adults now. So these are adults who have tested. No, you went ahead to masters. Go back to adults for me. Back to adults. Right, thank you. So again, they have tested positive. They may be asymptomatic. They may be mild. They may have moderate symptoms, and they may have severe symptoms. In those who are asymptomatic, they do the self-isolation and rest. They don't exercise for 10 days from the positive test. Cardiovascular testing, not really necessary for them to consider return to play. But if they do so, they must do it slowly and under the guidance of a certified trainer. If they have no symptoms after that, fine, they can return to play. If they do develop symptoms, then they will have to have further investigations done. Same thing with mild symptoms, self-isolation and rest and no exercise for 10 days from the symptoms onset. They should have full resolution of the symptoms. The cardiovascular testing may not be necessary unless the history or the clinical course has suggested that it's necessary. And they can follow the return to play guidelines we mentioned before. In moderate symptoms, whether or not they have cardiovascular symptoms, they have not been hospitalized. Again, from symptom onset, 10 days of self-isolation until the symptoms have resolved. No exercise until 10 days after symptom resolution, so that's a convalescent period. They would undergo evaluation by a medical professional and do the basic tests for myocarditis. If those test results are normal, then they can proceed to return to play gradually under the guidance of the certified trainer. If their tests are abnormal, then proceed to doing things like monitoring the cardiac enzyme and consider cardiac magnetic resonance imaging. If any of these groups start developing symptoms while they're returning to play, then we go on to do further investigations for myocarditis. And if the magnetic resonance confirms any injury, then they will have to follow the return to play guidelines based on myocarditis. If it doesn't confirm any injury, then they can consider exercise testing and the ambulatory rhythm monitoring to make sure there's no electrical problems with the heart. In all of this, we still consider other diagnoses that might be affecting the patient. With severe symptoms, people who have been hospitalized, during hospitalization, you monitor their blood tests and cardiac imaging. If those are normal, then they rest. They should have no exercise while they're symptomatic. And after symptom resolution, they still have 14 days of convalescence to go before they should consider return to play. In those who have clinically significant cardiac injury, they follow the guidelines for myocarditis that we listed at the very start. In those who are normal, they can resume slow resumption of activity and return to play if that is okay. But if they run into any problems, then we have to proceed to the more involved testing that I listed before, the cardiac magnetic resonance imaging, the blood testing, ambulatory investigations of the heart rate and all of that. And then you have the masters athletes who may have underlying conditions like diabetes, hypertension, and all of that. I won't go through that algorithm. I'll just say that we need to remember that so up to now, we have practiced what is called evidence-based medicine. In this case, what the College of Cardiologists has done is use past experience with other conditions to set up these guidelines. And these guidelines might change as we go along and we gather further information about this disease. All right, next slide. I'm going to skip the masters athlete and move on. Okay, now what about the post-COVID period? What they have found is that they have what are called long haulers, and I put that together with what is called the post-intensive care syndrome. And by definition, this means that people have persistent symptoms up to months after acute COVID-19 illness. And the population most at risk are older adults, people with comorbidities, those who have been hospitalized, or those who have had mild to severe disease. And what my friends in ICU have told me is that males who are obese have the worst outcome. That is what they have found. Okay? What are the symptoms? They can have fatigue, shortness of breath, cough, joint pains, chest pains, and this is thought to be related to scarring and injury of the lung and vascular tissue, the blood vessel tissue. There are other things like brain fog, depression, anxiety, muscle pains, headaches, palpitations, that's racing of the heart, intermittent fever, post-traumatic stress syndrome. These can be consequences of being in ICU and placed on a ventilator, being totally relaxed for weeks or months. So the point I want to make is that prevention in an athlete, this can ruin an athlete's career, because it's not that you're going to get up out of ICU and go back to your regular activities tomorrow. It may not happen that way. So the best form of treatment is prevention. Okay, let's move on. So there's a common sense approach. Prevention is key. Public health guidelines should be observed. Suppression of the viral spread through surveillance, restricted travel, restricted activities, restrictive group gathering, that sort of thing. We want access to testing to be more available, and we want results to come more quickly. As it stands, it is very difficult to manage patients because it takes so long for test results to come back. In fact, you can't depend on the test results to guide you in managing patients as it is now. The vaccination is coming, and in all of this, we have to recognize that the National Health Services has limited resources, and that has to be part of the mix. Next. Now, this is a very important part. Remember, I said that we don't have all the evidence available to us about this disease now. So far, we have practiced evidence-based medicine, and we could sit down and tell you the risks versus the benefits of doing things. With this disease, we don't have all the facts, all right? So it cannot be the sole purview of the clinician in the absence of quantifiable risks to advise an athlete about whether or not they should return to play. There has to be a conversation, and that conversation should center around the clinician's estimation of the risk versus the patient's tolerance for risk assumption. And three things should guide that conversation: the severity and duration of the illness, the baseline fitness of the person, and the short-term athletic goals of those people. Okay? There are some gray zones in all of this that we will have to explore. So, for example, the athlete's heart is not like a regular person's heart, and there are some gray zones that have not been studied as yet. So we don't know, for example, what is the normal blood test results in athletes for cardiac injury in some cases. We haven't done the studies to assess, well, what is really severe injury, because after exercise, you can have a rise in the cardiac enzyme, which is not related to any cardiac injury at all, right? So studies will now have to be done to guide us as to what is normal for an athlete as opposed to a regular person. And because of this now, gray zones, we now have to start having this conversation with athletes when we are advising them about return to play. All right, next. All right. The next slide, please move on. Let's move on. What's a common sense approach? Really, for those involved in planning events, I put this slide in there. Rehearsed emergency action plans. I worked with an international organization that did what they call desktop exercises on a regular basis to manage emergencies. This is like a dry run of an emergency. We learn who is responsible for what, who must be contacted when, and what they must do after that. Automated external defibrillators will have to become commonplace at our events. They must be immediately available for use on athletes, event officials, security personnel, vendors, and spectators. The reason being that even in people who have had mild disease and seem to be over it, you still have those who have had heart attacks, have had strokes, have had pulmonary embolism, right? So even after the convalescent period, you still have a few people, as I said, the long haulers, who are at risk for these things, and they may come to an event, or an athlete who has had this may come to an event feeling that they have followed all the guidelines and they're good. And then they go out and run and something happens. So AEDs will have to be a commonplace at our events. High flow oxygen supplies, and I want to say supplies because you may have to supply more than one athlete, more than one person with oxygen at any one time. You must have emergency medications, both for the heart and the respiratory system, and you must have transportation in place. These are some of the literatures that I used to research the topic. Next slide. And I want to say respect and thanks to GC Foster and the Jamaica Association of Sports Medicine.
All right. All right. We say thank you, Dr. Hanson, for that very comprehensive presentation. And at this time, we're going to go into the Q&A section. And I see here we have 4 questions. So we're going to quickly go through those questions. I'm going to start off with the first one that was asked, and it says, good day. So if you are asymptomatic, how would you know that you should go and test if you are tested positive or negative?
Okay. Most people who are asymptomatic don't go and get tested because they may not, the only way, many times what happens is that they may have a relative or somebody at work who has tested positive and is symptomatic. And then in contact tracing, they are tested and found to be positive, even though they're not having symptoms. The government would not be able to supply enough testing kits, the PCR testing kits, to test everybody. And so initially, they were trying to catch all the cases. When you have community spread, and it is so widespread, there is, what they do is surveillance. So they will go into, they have what they call sentinel sites in various communities. They will go in and do random testing, and that gives them an idea of what is happening in the community. If tests start to rise, positive results start to rise in a community, it tells you that you have a hotspot there. And that's why you will see the government going and put in place certain restrictive measures in certain communities when things start rising. That's what's happened in Manchester. But to test everybody is just not possible.
Okay, thank you. All right, so this next question is, what about persons/athlete who contracted the virus and were not treated at all using any of the treatment that you have made mention?
Well, it depends on how severe they had it. If this person had it mild to moderate and they observed the guidelines about self-isolation, resting, observing convalescence, then that's fine. You take your chances if you have the severe disease or critical disease.
Okay, seem to have frozen. Dr. Hanson, still with us?
Seems to be out. He's back. He's back.
Man, Wi-Fi for you.
Next
Okay.
question.
Okay, all right, then the next question, Dr. Hanson, is I think there should be an well, the person is asking for an explanation as it relates to the vitamin C usage not
Yeah.
being tested for its validity when that was one of the number one recommendations to safeguard against the virus.
Now what I cited in my presentation was IV administration of vitamin C. That has not been tested. You can still take your oral vitamin C, just don't overdo it. But the high dose IV vitamin C it hasn't been studied yet. So they can't make any comments about that.
Okay, no problem. I'm going to move on to the chat. Mrs. Denton asked a question. So she said, previously we were told that the evidence shows that the prognosis is best in those patients who are able to exercise, especially the symptomatic patients. And in your presentation, we learned that athletes should not exercise for 10 days after returning a positive test. Is this a new development for all or relevant to athletes only?
Well, Gwyn, I don't know if you can comment, but I don't recall any guidelines suggesting that while you're sick, you should exercise.
Yeah, there are no guidelines about exercise while you're sick. It's actually not recommended because of the issues with especially myocarditis, which you don't know about. So
Right.
actually, once you're ill, it really should rest. There are no guidelines. The only exercises that would be recommended would be deep breathing to keep the lungs expanding. But physical exercising that would stress your heart would not be recommended if you have the virus, because that's a risk of you having a heart attack or some major cardiac event. So no, not while you're sick. There's no exercise while you are symptomatic and infected.
What
At
I would add,
the time frame when David's talking about the 10 days after is when you are asymptomatic. It's not about when you test positive. It's 10 days. So 7 to 10 days after you have no symptoms. So when you have no symptoms, 7 to 10 days of having no symptoms is when you are recommended to go back. So not while, so no exercising while you have the virus. I haven't seen anything to support exercising while you have the virus.
so what I would say too is that in Jamaica, we have a thing where we said when you have the cold or the flu, you go and sweat it out. I used to hear that as a child.
I do it.
We have had athletes who dropped dead on the field from something as simple as the flu virus because they went out and were sweating it out. But the flu virus affected the heart and they died on the field. And that happens in the United States as well every winter. That is why you hear a certain death count from the flu virus in the winter, during the winter in some of these countries. So we don't recommend that while you're sick or convalescing, you should be out doing any vigorous exercise at all. Breathing exercise, fine, but nothing too strenuous.
Okay, thank you for that response. There's some about the RTP regimen, but I know Dr. Jones will be going into more detail as it relates to that. So would you like to wait later to
Sure.
answer that question? Okay, we have about 3 minutes left. So this question is coming from Mrs. Brown, and she's saying, would you suggest then that in training the coaches and school nurse, if available, do baseline measurements with athletes using BP machine and pulse oximeter and otherwise monitor as indicated and do follow up?
Well, those certainly won't hurt for you to monitor those things. That's standard even when you go into business places now, maybe not the blood pressure, but at least the pulse ox and the temperature as a screen. And it's part of the guidelines the JSM has put out there for return to sporting activities, starting at the point of departure, checking those things and checking them even at the event to make sure that people are not running a fever, not having any symptoms, and that they're okay.
Okay.
The other thing I should have added with regards to the events is that we, the people who are providing coverage, will also have to be provided with protective gear. So gowns, face shields, masks, gloves, this sort of thing. So it's not, and it's not just for us, because remember, we have the scout who provide services to move athletes who collapse on the track and that kind of thing as well.
Okay.
So, yeah.
All right, I'm gonna ask you three questions because I feel like they're very, we're able to answer them in the time left. So the first one is, what are the implications for athletes who did not know they have contracted the virus? That's the first. And then how does a coach plan for this?
The first is hard to answer and that is why it is wise, if we are going to resume activities, testing becomes important, right? The clubs, event organizers, that sort of thing, it will become important. And this is something that the JSM has also said, that under certain circumstances, athletes should be tested. And we all talk about the bubble, testing them before they get into the bubble, testing them while they're there to make sure that they're negative, right? So those guidelines are out there as to how we should go about doing this.
Okay, all right. I'm gonna ask one more question. And this question is on, is it advisable is it advisable if an athlete tests positive to make sure that an echocardium is done?
That will depend on how severe they had the condition, whether or not they had cardiovascular involvement. You will note in the algorithm that if they had mild symptoms, it ran its course, they have observed all the guidelines, and they want to return to play gradually, then they can without testing. But that is against the background of their clinical course and what their previous history was. If they have a previous history that is of concern, or if at some point in their clinical course there was reason to wonder, then I would err on the side of caution and say, let us get this done. And that's part of the algorithm, if you go back and look at it. So using clinical judgment, taking the history and all of that is very important in those who have had the mild disease. In those who have had severe to critical, and sometimes even the moderate cases, it's still recommended that it's probably a good idea to do the screening. In those who are sure they have had myocarditis, then definitely you have to do the basic screening and may need to go on to the advanced screening as well.
Okay, all right. We're going to end this question Q&A session here, and we're going to hand over back to Mr. Beckford, who will introduce the second speaker. And then at that point in time, we'll have another Q&A session after that second speaker. And if it is that we have enough time, then we will ask all the other questions that weren't answered in this first session. Mr. Beckford.
Yeah, so thank you very much, Mr. Lamont. Dr. Hanson, might I just add my two pieces just to say that were well comprehensive, well-defined presentation has been shared by the audience. And I must say that so far, so good. Ladies and gentlemen, we have now, just to remind you that this is our webinar, J.C. Foster College, in association with the Jamaica Association of Sports Medicine, presenting to you webinar COVID-19 and the athlete returning to sport. And this is an interesting topic, and it is one that nobody would want to miss, especially in a time like this. Now, we have just had our first presenter, Dr. Hanson, and now, ladies and gentlemen, we'll be looking at our second topic, which will be covered by Dr. Jones, and coincidentally, another doctor out of the cool Manchester. So I don't know if it's indicative of something, but both presenters this evening are from Manchester, are coming out of Manchester. Dr. Jones is Jamaican national. He is a consultant of orthopedic surgeon at the Mandeville Regional Hospital. He's also an associate lecturer in the Faculty of Medicine, of Medical Sciences, Department of Surgery, Radiology, Anesthesia, and Intensive Care, University of the West Indies, Mona. The chairman of Therapeutic Use Exemption Committee of the Jamaica Anti-Doping Commission, JADCO. President of the Central Chapter of the Jamaica Association of Sports Medicine, board member of the Usain Bolt Foundation. And Dr. Jones has had his education from the University of the West Indies, Mona campus, Princeton University, Monroe College, Knox College High School, Knox Junior School, and the list goes on. His academic qualifications included those achieved at the Advanced Cardiac and Life Support certification, the Advanced Trauma and Life Support Instructors course in Trinidad and Tobago, Doctor of Medicine in Orthopedic in the University of the West Indies, Advanced Trauma and Life Support, American College of Surgeons, Fellowship of the Royal College of Surgeons, Edinburgh, the Bachelor of Medicine and the Bachelor of Surgery, University of the West Indies, Mona, and also a BA in Chemistry, Princeton University. He also has had numerous highlights and honors, which would have included Intercollegiate National Volleyball Championship at Mona University of the West Indies, the Al Phillips Award for the Best Field Events Performer at Intercol, Kingston, Jamaica, and also Senior Sports Award in Track and Field, Princeton University, and he's an All Ivy League outdoor team member. In 1987, he was the president of the West Indian Students Association at Princeton University, and the list goes on and on for Dr. Jones. He's also looking at, I've also seen here where he has had a stint in the Da Costa Cup, team member at Monroe College, volleyball team member at Monroe College, and also the Interschools Christian Fellowship at Monroe College. Might I go further to add that included in the long list for Dr. Jones is also the school track team member for Knox College, school choir, Knox College, and in 2005, he has been the grade 3 medical officer in orthopedics at the Spanish Town Hospital, grade 3 medical officer in orthopedics at the Kingston Public Hospital, chief orthopedic resident doctor at the UA Mona, senior resident doctor in orthopedics, UA Mona, and senior resident doctor in orthopedics, Kingston Public Hospital, and the list goes on and on in that area. We also see in 1997 where he was the junior resident doctor in surgery, DM part 1, University Mona, Hospital Mona. For the community services, is a very long list, but I've also seen here where Dr. Jones served as an under-23 track and field team doctor to the NACAC championship in Colombia, Also in cricket, 2007, where he as a medical volunteer doctor for the World Cup cricket in Jamaica. And he also served as medical volunteer for the IFNA Netball World Championship in Jamaica in 2004, and in medical volunteer for the IAF World Junior Games in Kingston, Jamaica. That was 2002. In 1993, he also served as a volunteer field events coach at the Monroe College. 2003 to present, the Jamaica Orthopedic Association. 2009 to present, the international affiliate member of the American Association of Orthopedic Surgeons. So Dr. Jones has also served in 1992 at the Trauma Surgery Conference for Northeast in Connecticut, United States of America. Ladies and gentlemen, you'll also note that his activities and interests include track and field, volleyball, swimming, field events coaching, and he's also a field events coach at the Monroe College to present. Ladies and gentlemen, the list wouldn't have afforded me, but at this moment, I want to introduce to you Dr. Jones.
Thank you very much, Mr. Duckford. A bit more than I would have hoped, but a situation sitting like this. I'd like to thank the GC Foster Group, Neil, Lamont, for hosting this webinar. The topic, I don't know if anybody who has approached, has gone from this side, dealing with patients or athletes who have had COVID and the return to sport. Everything has been about preventing COVID and returning to sports. So I think it's a great topic, and thanks for giving me the opportunity to share on it. All right, so that's quick declaration. Yes, David, Dr. Hanson is now the president of the central chapter, and I'm now president of the national body. So some of my slant might seem a bit coming from that side in terms of facilitating the return to sports. And you did mention I am the chairman of the Therapeutic Use Exemption Committee of JADCO, and as a result of that, some of what I say at the end will have to deal with that. All right, just a quick introduction. Remember, we're talking about the novel coronavirus, and novel meaning new. And like Dr. Hanson had said earlier, a lot of the stuff that we're still learning stuff, and a lot of this, we won't learn a lot of the stuff or know a lot of stuff for at least another 5 years from the onset. So by 2025, we should have a better grasp of everything. So we're pretty much making up as we go along. Studies are, a lot of the studies that we will quote and so forth are studies that were done in 2020 and have just been released in 2021. So be careful of listening to individuals who speak with authority of the virus and playing it down, because the bottom line is that a lot of the stuff we do not know, because it hasn't happened yet, or we haven't seen the long-term effects of it. So what I'm presenting to you is what we do know currently and based on what is current best practices. All right, so the objectives of this talk, we hope to identify the roots of spread of the virus. A lot of that stuff was done previously by Dr. Hanson. Identify the organ systems affected by the virus and kind of go through them briefly, and then that can guide us as to how best we can go forward in return to sport. Understand the damage to the different organ systems that is caused by the virus, and then having done all of that, having a basic understanding and going forward, recommend a systematic return to physical activity after a positive infection. Now, how does it happen? Like the pathophysiology, how does it happen? So I recognize that the audience is a mixture of medical personnel, coaches, and non-medical personnel, athletes, etc. And as a result, I will try to ensure that the slides and so forth reaches out to the different groups. And just incidentally, all such persons are actually parts of the Sports Medicine Association, from teachers to doctors, coaches, etc. All can be members of the Sports Medicine Association. All right, so how does this happen? So the SARS-CoV-2 virus, or otherwise known as COVID-19, it binds to a specific protein on the human cell, right? And that protein is the angiotensin converting enzyme 2. There's a angiotensin converting enzyme 1, which occurs early in the cascade of the breakdown of the compound angiotensinogen, and angiotensin 2 helps to break down angiotensin, which is a very potent vasoconstrictor, one of the factors that causes you to increase your blood pressure by various means. All right, so once it binds to this receptor, what happens is that this binding to the receptor allows it to enter the cell, and by entering the cell, the virus now takes over the whole manufacturing mechanisms that the cell has to manufacture stuff for us, for the human body. So the virus now commands the nucleus of the cell by inserting its DNA, well, its RNA sequence from inside this capsule. When it gets inside, it sends its RNA chain, which commands the nucleus of the cell, and then now it starts to produce virus particles. And these virus particles then are now extruded from the cell, and then they go and infect other cells. Now, one of the issues with the virus binding to what we call the ACE2 receptor protein on the surface is that once it does that, it actually now causes the cell to shed other such receptors on the surface. And as a result of that, we lose the ability to break down angiotensin and angiotensinogen 2, and also bradykinin, which are compounds which, like I said, cause an increase in blood pressure. Bradykinin is a potent inflammatory agent that can cause you to lose fluid from your vessels into and around your cells, what we call third spacing or the interstitial space, and cause that can lead to swelling. And what that does, like in the lung, is that when you get this increased fluid around the lungs, and it reduces blood flow to parts of the lung, it interferes with the gaseous exchange. Now, just briefly there, what the ACE2 receptor does, the protein does, it breaks down angiotensin 2, which is, like we said, a potent vasoconstrictor. It causes your blood pressure to go up, and then by breaking it down, it allows your blood pressure to normalize. This substance also acts on the suprarenal glands, or the adrenal glands, in particular the cortical part of that, and it causes the production of a drug or a substance, a hormone known as aldosterone, which causes it to retain sodium, and retaining sodium also causes it to retain water as well, which also leads to increase in blood pressure. It also acts on your brain, in particular your pituitary, where it causes it to increase vasopressin, which is a drug released by the brain, which causes the blood vessels to constrict, which also sends up your blood pressure. So breaking this down helps you to normalize blood pressure, and a lot of medications are designed towards that and blocking the production of this drug. Just there. So we mentioned those things there already. Vasodilation, a reduction in blood pressure when you destroy it. Aldosterone production causes it. Breaks down bradykinin. Bradykinin will cause the arteries to dilate and the veins to constrict. So it results in increased pressure buildup in the capillaries in the blood vessels, which cause the fluid leaking out of the blood vessels into the spaces around the cell, which leads to swelling, and that can impair your oxygen supply. Now, your organ systems that are affected by COVID-19 are pretty much, they involve mainly the systems with high levels of this protein, the ACE2 cell membrane protein. And this protein is common in cells that have produced mucus or protection for their surfaces, and that includes the respiratory system, it includes the cardiovascular system, it includes the kidneys, the gastrointestinal tract, and the nervous system. And those things are outlined there. Now, the respiratory system, after this, I have a lot of Hanson that got this before, so we just gloss over this. Remember, the respiratory system is divided into an upper respiratory and a lower respiratory tract. The upper respiratory tract symptoms, so the upper respiratory tract includes the nose and the paranasal sinuses. It includes the mouth, the pharynx or the throat, and the larynx. The larynx is where the vocal cords are, or the voice box, which is what we would know in lay terms. Below the larynx is the lower respiratory tract, which includes a short conducting system, which is the trachea, and then the trachea, which is the main area of the windpipe, breaks into two, which are two main bronchi, and then the bronchi breaks up and divides like a tree and its branches to get into smaller and smaller conducting tubes known as bronchioles, and then that eventually culminates or terminates in air sacs known as alveoli, which is pretty much the lung tissue, and that is responsible for the gaseous exchange, allows you to exchange oxygen and carbon dioxide, plus some other gases, but oxygen and carbon dioxide, which are exchanged in these sacs across the membrane into the blood and into the sacs. All right, so when you affect the upper respiratory tract, so by irritating, it can cause symptoms associated with irritation or infection of these areas. So what you can get from there are a runny nose, also known as a rhinitis. You can get a cough and a cold by irritation of your pharynx. You can get a fever, which is more a systemic phenomena, and you can get sinusitis as well. So these are some of the non-specific signs of a COVID infection of the upper respiratory tract. And it's the same for pretty much all viruses that can infect these areas. But as your lower respiratory tract, this is below the larynx, the trachea, the bronchi, and the bronchioles, and the alveoli and the lungs, you can infect any part of this this tract, where with the bronchioles, you can get a bronchiolitis, so you can get a bronchitis if it's the main bronchi. And when you get infections of these areas, you can get the structure gets it becomes inflamed, and one of the responses to that is that the smooth muscle which goes around it contracts, and then so you can get constriction of your airway, which can lead to wheezing and difficulty breathing. As when it goes further down and infects the lung where the alveoli are, you can get you can get a viral pneumonia, or you can get a secondary bacterial pneumonia, which can result in the sacs being filled with fluid and pus, and that will ultimately interfere with your ability to exchange gases across your lung surface. So just from a medical point of view, for those medics among us, so for a pneumonia, when you get a pneumonia, remember that this involves the air sacs of the lung. So you get pretty much a whiteout of an area of the lung like this here. So this over here on the right of the screen is like normal lung tissue. The darkness just represents air, which doesn't show up on X-rays. And if all these air sacs get filled with pus or fluid, some parts say, you'll get a certain area that becomes white, a whiteout of a part of the lung, and that would suggest a pneumonia. If it involves the bronchi, which is the airway, which conducts the air to these sacs, so it's like the branching of a tree, you don't get the whiteout, you get this streakish kind of white increase in the outline of the airways on the X-rays, as emphasis by here. So let's look at more, here as well, you can see the airways becoming wider and broadened. Up here would be more normal airways. These white streaks going out would represent the airways going out to the air sacs of the lung. So when they become highly visible on an X-ray, it usually suggests that there is inflammation thickening on the wall, and then they show up like this on your X-ray. All right, so in terms of the respiratory system, the lower part of the respiratory, you can get damage to the lung. As mentioned before, right after Hanson, this can lead to scarring of the lung. And if you have scarring of the lung, it will interfere with the ability to exchange gases across the lung surface. And as a result, it can lead to shortness of breath, especially when you exert yourself. The lung has a decent capacity to respond to loss of lung tissue. So if you have lost that area of lung due to scarring or damage, the other area of the lung can hyperinflate to compensate for the loss of that area of the lung. And in terms of the cardiovascular system, the structure of the ACE2 receptor proteins here interferes with the heart's ability and the vascular system ability to respond to angiotensin 2 and the various effects as a result of that. Hanson mentioned about the myocarditis of significance that affects between 7 and 23% of ICU COVID patients. All right, so the effect and the percentage of effect of the persons who have little or no symptoms is really not known because they haven't screened extensively in mild symptomatic COVID patients to know. So the studies that we have are really those of the very sick individuals, those that are in hospital that we can test and check for these things. So 7 to 20% of ICU patients. And that can lead on, like Dr. Hanson mentioned earlier, to things like heart attack and death. What they found in a study out of the States was that in patients who died in intensive care, it was only, and they did autopsies on, it was only about, it was like less than 14% of them that actually had evidence of myocarditis in those that have died. So that wouldn't have suggested that the myocarditis would have killed them. Now, it is rare that you will find an individual, an elite athlete, getting a myocarditis that can lead to sudden cardiac death. And the example here, you can Google this, is Michael Ojo. He's I think it was Senegalese, I don't quote me on that, but Africa descent, was discovered in Africa, brought to the States to play basketball, played for, I think it was Florida State University, and didn't make it straight to the NBA, ended up playing basketball in Serbia. And while there, he was caught the virus, mild, and returned to sport. And then during a training session, he actually had a heart attack and died. So he ended up with sudden cardiac death and died. As the only individual that I have found who had COVID, returned to sport, and ended up dying from a cardiac event. Now, whether or not it was from COVID that this happened, or, you know, individuals like us of African descent, we are predisposed to this sudden cardiac death phenomenon, especially in our 20s or 30s. It happened to a couple of our schoolboy players where they've had a major cardiac event on the field of play. So we are predisposed to this kind of condition. It's hard. It's happened to professional footballers in Europe. You know, so it's something that affects individuals of African descent. There's really no way of screening for it. So whether or not this was COVID related or just related to sudden cardiac death that recurs in some athletes is not known. So that is still under discussion. All right. So the effect on the heart, it can be temporary or it can be permanent, and that's why all those tests, which we will review at the end of the talk, to be done before return to sport are recommended. And you get heart attack, you can get an abnormal heart rhythm, and like I said before, sudden cardiac death. In terms of the blood vessels, you can get fluid leaking out of the blood vessels into the space around the cells, which can lead to swelling. You can get clotting as a result of this, and the person can lead with blood clots. It can affect the heart, like I mentioned before, cause heart attacks. It can affect the brain, which can lead to a stroke, or it can actually affect the limbs, which can lead to muscle death, and eventually, if unchecked, can lead to loss of the limb. So the nervous system, the viruses are associated with headaches or a new loss of the taste of smell. All right, so you can have new loss of taste or smell. Somebody had taste loss or loss of smell from before, then that wouldn't be included. So a new loss of taste or smell due to the effect of the virus on the olfaction nerve, which lies in the roof of the nose. And then you can get psychiatric and neurological complications again from having the virus. The issue with the psychiatric and neurological complications is that what they found is that a lot of those are similar to those associated with patients who have been in intensive care. So you really find these kind of changes in individuals who have been in intensive care, and they so it's not so sure how much of that is associated with the virus or much of that is actually associated with being in intensive care. So you can get, like say, psychosis, you get post-traumatic stress disorder, depression. That's supposed to be nerve damage and not nerve damage. I don't know my spell check. Missed that. You can get dementia, dementia type syndrome. Now, the renal system, initial studies out of China, I remember a lot of initial studies came out of China because that's where the virus and the first major outbreak took place. So the initial studies of China suggested that the kidneys were not involved. The kidney involvement was rare. However, more recent studies out of New York, and just anecdotally speaking to a colleague of mine who actually works on the isolation ward at the Man Regional Hospital, he was the first one who really clued me into this, that well, in New York, as out of New York, 30% of infected patients develop renal injury. All right, and we have had a number of those in Mandeville. A lot of times, even after the lungs recover, the kidneys never recovered, and that actually ultimately led to the patient's demise. Now, in ICU patients, we found that 78% of patients in ICU end up with some kind of a significant renal insult, with 35% of them requiring dialysis. How many of them end up going on to develop to need long-term dialysis? We don't know yet, because all of this is still information that is evolving as we speak. I believe this is a result of secondary to clots obstructing the renal vessels, the kidney damage, and all the various issues that occur from there. And this is one of the reasons why some of the experts refer to coronavirus not so much as a respiratory illness or virus, but as a vascular one, because a lot of the damage that is done is as a result of the damage that it does to the vessels that supply our major organ systems. To the gastrointestinal tract with the liver, they found that some patients hospitalized for COVID-19 had increased levels of liver enzymes. In particular, these two known as alanine aminotransferase and aspartate aminotransferase were enzymes in the liver used to break down various substances. And anytime those go up in the blood, that suggests there's a certain amount of liver damage. Now, the good thing with the liver is that the liver has great regenerative powers, and there hasn't been anybody documented so far that has come out of COVID with severe liver damage that required long-term care for it or liver transplant. However, you must recognize, therefore, that individuals who have liver damage as a result of cirrhosis, whether from a viral cause or from alcohol or substance abuse or drug, otherwise, they would be at increased risk for further liver damage and complications associated with that. Some studies have shown that people with pre-existing liver disease who are diagnosed with COVID-19 are at higher risk of death than people without pre-existing liver disease. And that's kind of academic, because patients with liver disease, liver is the main detoxifier of the body and important in many pathways, including your immunity, your digestion, and your circulation. So remember that your liver, so the fact that persons with pre-existing liver disease dying from catching COVID virus at high risk of dying is not hard to believe, because the liver is so vital in our well-being. And like I said, chronic liver disease such as hepatitis or cirrhosis or stuff like that. Like I said, the liver from COVID alone, the liver has high regenerative properties, and like I said, I did not come across any cases of significant liver damage from COVID that resulted in a long-term sequelae. And like bowel, people forget when it can cause nausea, vomiting, and diarrhea. Remember, China, they came up with a swab, actually a rectal swab that you can do to test for the virus, which actually says more accurate and probably, well, depending on who you are, I guess, more easily tolerated than the nasal swab. But you can swab the rectum to test for the viral particles as well. And then acute pancreatitis, the pancreas is one of the main, it has both exocrine function that it produces hormones that go directly to the digestive tract. It has endocrine function, which produces hormones like insulin, which go into the bloodstream and act that way. And you can get an acute pancreatitis from COVID, and that can lead to various complications associated with that. Which, I mean, acute pancreatitis can lead to lung damage from the release of enzymes which destroy lung cells and lung tissue, and then can result in respiratory issues from that as well. Now, return to sporting activity is really what this talk was hinged on. So I told you all of that to tell you this. All right, so again, like Hanson mentioned before, prevention is the main thing, but this talk is about those individuals who have been infected with COVID. And suppose, as far as we know so far, being infected does offer you a certain amount of immunity. How long that lasts and how absolute that is not known. So as a result of that, even if you were infected with COVID and you return to sport, prevention, reducing your contact with any infectious person becomes important. So still stay away. That's because you were infected and you think you're immune, not like chickenpox where you can go and rub up with all the chickenpox persons. You still need to social distance. You still need to reduce the inhalation of droplets. So you need to wear a mask when you are able to do so. Reduce hand contact with infected surfaces. And that just means not touching everything around you, leaning up on certain surfaces, especially when you're out in the public. And if you do make hand contact with an infected surface, you want to reduce the contact of your contaminated hands with the areas, all those areas that we mentioned in the beginning, which have these high ACE2 receptors, such as your eyes, your nose, your mouth, and your genitals. We want to reduce your contact of your contaminated hands with these areas to reduce the risk of infection. And in order to do that, so you reduce the contact of your hands, and if you can't do that, you make sure that you sanitize your hands or you wash them regularly. Once you contact something outside of your normal sphere of things, you should sanitize or you should hand wash. I mean, if you're in your own circles after you shower and bathe and you get a good wash down, if you only there and your hands are now clean, you touching your eyes, nose, mouth, and other areas is of little or no risk because your hands would have been sanitized. Hand sanitizers have to come in contact with potential contaminated surfaces, and you can use barrier methods such as goggles or face shields if what you're doing allows that. I put an asterisk there beside gloves because only if you have an open wound on your hand, so there's a breach in your skin, you should be really caught up in about wearing gloves. Once your skin is intact, you have no wounds. If your hand comes in contact with a contaminated surface, there's a very low, there's no documented transmission of it going through your skin. It's going to transmit, we said, through your eyes, your nose, your mouth, and other sensitive areas. All right, so gloves only if you have like a cut on your hand or whatever. Well, once you contact anything outside of your own personalized bubble, sanitize or wash. Now, what to do before returning? Now, this will depend on the course of your disease. So you have mild to moderate symptoms that did not require hospitalization, and all you did was symptomatic treatment. Dr. Hanson spoke about 10 days after of being symptom-free. The studies I've seen coming most out of Europe talk about 7 days of being symptom-free, so 7 to 10 days, but no less than a week of being symptom-free that you should consider returning to sport. Now, if you have had a major event where you ended up in intensive care, you ended up on a ventilator, and you had signs of, so you had to be admitted to hospital, you ended up on a ventilator, some kind of ventilator report, and you had signs of having a myocarditis or so forth, that changes the picture altogether. And I'll mention them again, Dr. Hanson mentioned before. If you are one of these athletes who have been through a severe course of the disease, you need to do some basic pre-participation testing before you return to sports. And this is after a period of you being asymptomatic. So you must do an electrocardiogram to check out the electrical activity of your heart, and possibly a stress electrocardiogram. And you talk about the Holter monitor, which is the 24-hour cardiac monitor, with like 24-hour monitoring of the electrical activity of your heart to see if there's any abnormality there. Those being normal, the role of an echocardiogram, people, they'll debate, the stories I've read debate, the need for it is if there are signs of cardiac compromise in terms of the function of your heart. So a person starts to become easily fatigued and relatively early exercise or whatever, then you can do an echocardiogram. The cardiac MRI is something that is recommended for individuals who had documented signs of a myocarditis when they were admitted. So that would have been determined by a normal electrocardiogram while admitted, or elevated cardiac enzymes, and in particular the troponin protein, which is one of the early cardiac enzymes that is released after cardiac damage. So for individuals who have definitely documented history and evidence of myocarditis after being admitted to hospital, they need to have all of these relevant tests to ensure that their heart is of such a nature that you can start to stress it and return it to exercise. Now, lung damage, if the individual has, so for, like again, those individuals who had a mild course, probably like a runny nose, a little fever, headache, or whatever, they were required hospital admission and they just isolated at home. There's no need for lung function tests. So all of these tests are for those individuals who end up with the virus and end up admitted to the hospital for a significant period of time and being on ventilator support. You should do lung function tests to check to see what the level of lung function is, their forced expiratory volume and their tidal volume. And so you need to measure these things to see if they are of such that the person can exercise safely. If you didn't have significant respiratory symptoms and required hospital admission, then the need for a lung function test is not recommended, because there's no need for it, because just you'll be able to tell by just your early exercises if your lung function has been compromised that much. Kidney damage, if you had signs of impaired renal function while you're in hospital, like in intensive care or whatever, in a step-down unit, then you need to do your renal function test, and you would not recommend that they return until those normalized. They did not normalize, they have to have some serious conversations about whether this individual should return to sport or not. Liver damage, like I said, the elevated aspartate and alanine transaminase tests, those, if you had signs of liver damage right in hospital, baseline liver function test afterwards is recommended. Most times, like I said, they return to normal because there have been no documented cases of severe liver damage from COVID that I have found in my perusal of this topic. So this liver function returns to normal. But if you did have abnormal liver function tests, then it'd be worthwhile getting those done before you return to sport and make sure that those are normal. And so far, most have been based on what I've seen. Pancreatitis is serum amylase. That's an enzyme released by the pancreas from damaged pancreatic cells into the bloodstream. And if you had pancreatitis from COVID, this would have been monitored during your time in hospital, and it would have been returned to normal before they would have discharged you. So whether you would need to do this or not would be debatable. If somebody had some serious abdominal pain boring through to the back, which is classical pancreatitis, then you might want to get this done before they return to sport. Now, the psychological symptoms consistent with post-traumatic stress disorder, I remember we said these were more common with those individuals that were admitted to intensive care. You need to get psychiatric intervention if they're having problems sleeping because of a general anxiety from having had the virus. Then you might want to prescribe, as a medical person, to have them placed on a mild sedative to ensure that they get adequate sleep, because athletes do not do well when they do not sleep properly. So that might be something you might have to consider. So if necessary, if they're really anxious, they're really afraid about coming around people and having a social phobia, then you probably want to recommend a psychologist, a psychiatrist who could, through behavioral therapy, usually that's what's recommended, help them to control these symptoms and these phobias. And then, like I said, if they're having problems sleeping, a mild sedative would recommend that be prescribed. No, I couldn't complete this without speaking about prohibited substances. No, remember that if you, and this is for individuals at different levels. So if you ended up in intensive care, and like Dr. Hanson spoke about the cytokine storm, the body's response to infection and inflammation is to produce various chemical substances which can cause further tissue damage and further impair your respiratory function and your cardiac function, other things. And then the glucocorticosteroids are given, and these are given in an intensive care. And also, I said, if you're having such symptoms, to dampen the effect of this inflammatory response, because these are anti-inflammatory. Remember that glucocorticoids are prohibited in competition. Okay, so they're prohibited in competition. So if you're tested out of competition, having just come from an intensive care bout of having the COVID-19, you need to mention it. If mention that you had it, have records, your medical records to document that you had the COVID virus, that you were in intensive care, and that these drugs were used to dampen, to treat and dampen your immune response, your inflammatory response to the virus. Remember, we've had one national athlete who was suspended for 4 years for being given dexamethasone for a condition which it was actually not recommended for, and he end up being banned for that for 4 years. So if you have COVID and you end up in intensive care and you get any of these glucocorticoids, then remember that you need to have the doctor's notes, copies of that to be submitted to JADCO as soon as you come out of intensive care. So you've had COVID, and you send all this in so that you can get a therapeutic use exemption. So if by chance any trace of these drugs shows up in your system when you're tested, in competition in particular, then you'd have an exemption for having had that used while you are being treated. Remember, certain diuretics, you can get fluid tested, some diuretics can be used during the course of your treatment for some acute respiratory conditions. Diuretics such as Lasix are used at all times because it's a masking agent, and it can hide other drugs which are banned at all times. That is banned at all times. If by chance a diuretic such as Lasix was used during your intensive, during your admission to the hospital, make sure that you have the relevant medical documentation to support it. I cannot overemphasize this. Now, if you have a mild case, so you have mainly mainly affecting your upper respiratory tract above your larynx, you have a rhinitis or you have a cough or whatever, and you take any type of oral decongestant for these symptoms, and these oral decongestants that you find in your over-the-counter multi-symptom formulas for Panadol, Cetamol, we have ibuprofen type stuff that has these decongestants in there, which are stimulants, right? But they, if you take an oral form of that, and you took that during your mild symptoms and so forth for symptomatic relief, so that you could do whatever, then make sure that you mention this. And these are, like I said, only banned in competition. You get tested out of competition, these show up, and make sure you document that you are taking them for whatever reason. And the truth is that for most of these drugs, for all these three in particular, the levels that show up in your urine are critical. So if the level in urine is higher than what would be expected for a certain use, then it's going to be flagged as an adverse analytical finding, and it's going to lead to problems if this was not documented prior, right? So the inhalers to decongest your nasal cavity, those are actually allowed, but still mention it because trace amounts can still get into your bloodstream. So you're allowed to use the nasal decongester, which have these substances to decongest your nasal cavity while you have upper respiratory. If you're still hearing me, my internet connection is unstable. So once you get all that, you get all the medical records together and you submit them to JADCO to apply for a therapeutic use exemption for the use, and this is where emergency situation and things. So the doctors would send them copies of the notes, what had happened, the course of your disease, and it will send it in to JADCO and apply for therapeutic use exemption. And once it meets the criteria, which is now what is best practice for treatment of these conditions, the therapeutic use exemption will be granted. Then this is after you've had the drugs. You don't get it before. So a doctor should not withhold the use of these prohibited substances in an athlete who needs them. They should be administered to save the athlete's life if necessary, and then apply for the exemption afterwards. Now, when you return to play, so after, so if you had mild symptoms and stuff for that thing, and you would return to play, or if you had all the major symptoms and you had all the relevant tests, which now makes you eligible or safe to return to play, we talk about the 7 to 10 days of being symptom-free before you go back to play. Remember that it is done gradually. So you don't come back to play and all of a sudden you start to run 300s and whatever there's a word. You come back, and gradual comeback might be just walking or doing whatever it is that does not cause the athlete to experience any type of symptoms at all. So this is walking or a light jog, stretching, light weights, whatever, but it must be as such that the athletes, as a coach, it must not cause any type of stress at all. It mustn't cause them to be short of breath, mustn't cause them to have any chest pain or anything like that. And that's what you start out with. Basic fundamental stuff that causes nothing, no symptoms at all. And then you do that depending on, and coaches will be familiar with that, to talk about the macro and the microcycles in terms of training and so forth. So this can involve like between a 2 to 6 week period of which you're doing very minimal stuff, stretching, minimal intensity cardiovascular stuff, and minimal intensity weight training. If you are on medication with a pre-existing conditions such as asthma or high blood pressure or whatever, you continue to take those medications, or diabetes or whatever, you continue to take those medications as prescribed by your treating physician. Remember, if you're a diabetic and you're on insulin and other hypoglycemic, that you need a therapeutic exemption for that, which you should have had from before. Once you have that condition, you're on those medications. Maintain your recommended follow-up with your treating physician. So just because you're back to training, if the doctor told you to come back and say every 2 weeks, 3 weeks, whatever, maintain, make sure you go back and you see them as recommended on a regular basis to pick up any change in your symptoms or your condition. And if anything happens, if you're doing training, you're doing something and something happens, you start to get short of breath all of a sudden, you start to experience some chest pain or whatever, you need to contact your treating physician or report to the nearest emergency room immediately to be evaluated. And when you go there, make sure you inform them that you did have the virus and you were treated and you're now symptom-free. Now, these are some recommendations similar to what Dr. Hanson had presented earlier, so let's fly through just a general chart. These were suggested by a panel. It's coming out of the UK. This is published in the British Medical Journal. That's the outlay. And this is the basic for return to sport. So it's pretty much the same setup as what Dr. Hanson had presented to you. If your illness required hospital treatment, or if you had a mild course of illness, after 7 to 10 days, you go back to phase return to physical activity. If you had a severe cause of the disease with signs of myocarditis and so forth, notice here they talk about 3 to 6 months of exercise restriction, right? So if your symptoms are mild, they say 7 to 10 days. So that's an upper respiratory tract symptom, loss of smell, whatever. 7 to 10 days after you've been symptom-free, you return to sport and return gradually. If you've had major symptoms, you end up in intensive care, you had signs of myocarditis as a result of, as signs of elevated cardiac enzymes, abnormal ECG, etc. You need to do all the relevant tests, and then your return to sport once those are negatives over a 3 to 6 month period. Do not, and coaches have to be very sensitive of that, and no, do not rush the athlete who has had signs of cardiac pathology. Lung pathology, like I said, you cut a lot more leeway because you don't get sudden lung death from having lung damage. Even if somebody cut out a part of your lung, the rest of the lung, like we said, hyperinflate will compensate for this loss of lung function. So if you have scar tissue and so forth in your lung that has removed a certain section of your lung and make it unable to exchange gases, it's most likely that the rest of your lungs will compensate for this. And so having those athletes go back after being symptom-free is quite safe. You know, if they start to have shortness of breath, whatever, you'd have them have their lung function tests done and so forth. But the critical ones are the cardiac ones, 3 to 6 months of exercise restriction, and it's done periodically. Every 6 weeks or so, you try to increase the intensity or whatever. Do not do sudden changes in training routines in patients recovering from COVID in all classes. All right, and then this how you can monitor this in training, and this is they stratified the athletes based on who had myocarditis or had post-acute COVID-19 symptoms, and this is based on the athlete's symptoms. And it's a phase reduction, and this is after being 7 days of symptom-free. So these are questions you need to ask the athlete, and that's why. And so phase 1 should be as such that is when they have it's like no exertion, they're not doing anything, or the training is extremely light, right? So so that, I guess, that occurs of breathing exercises, flexibility, stretching, and balance, or gentle walking. And it can consist of more, provided that the athlete has no symptoms. All right, so that is no exertion at all, or light training, or very light training, you know. And then after that, you talk about increasing the intensity of the workout. So that's increasing the cardiovascular demands, increasing your resistance work in training and so forth and thing. And that's still considered light. In phase 3, you can expect the athlete to be to breathe hard in these cases. That's what I think. But this is after you've gone through the first 2 phases and you're gradually increasing the exercises going up, you know. And they talk about doing the intervals. They talk about 5-minute intervals of 5-minute bursts of aerobic activities, and then you have a recovery period, and then you do it again, you know. I do it as a day-to-day basis, as tolerated, always being sensitive to the athlete's symptoms as they do these things. Remember that they should not at any point in time be uncomfortable or unable to cope. When you're fully healthy, you have no COVID thing, you know, sometimes you will train until you want to throw up or you feel like throwing up. We do not encourage that type of activity when somebody is recovering from the virus in all, whichever level of the virus at all. Do not work the athlete that hard. Everything should be gradually to push to get back to a full level of training. And I mean, they talk about monitoring the mood out here. We're not that sensitive towards mental illness and compromised mental status, but you need to be sensitive towards it. And the athletes, sometimes they might be apprehensive because the virus currently still carries a stigma. Where, I mean, some of us from the hospital, we go out in public, and for those of us in Mandeville, I know people have heard, oh, they came from Mandeville, or they work at Mandeville Hospital, and all of a sudden people start to scatter. Like, say we have leprosy, which wasn't necessary because, you know, leprosy is not contagious that way. But that's kind of how we're being treated. A lot of people who have caught the virus are being treated us like lepers and avoid it. I know of medical personnel, doctors, and an individual who had it, and that doctor pretty much having the patient wait outside and short of throwing him the medication, never really saw him, just wrote up something and dismissed him without seeing him or examining him properly, listening to his lungs or anything like that. And that can have an effect on somebody's mental state. So it's important that we are sensitive towards that as medical personnel and as coaches. All right, so those are the references that I used to cope with this talk. A lot of the talk was based on what we, from what we practice in the Association of Sports Medicine. And when I looked around the web, I looked at various articles and so forth, it pretty much concurred with such stuff that we have recommended and stuff that we saw based on just basic first principles. So you'll find that wherever you are, that a lot of what I have said and so forth, individuals will come up with it independently, you know, and come up with the same thing, just based on the basic first principles, based on the nature of the virus and the systems that it affects and how to get back to sports. Thank you very much.
All right. We just want to say thanks to Dr. Jones for that very comprehensive presentation. And if we were in a room, we'd give him a hand. At this time, we're going to go into our second Q&A. We have quite a few questions, so we're going to try and answer as well. We have about 11 to 12 questions. So we're going to try and answer them between yourself and Dr. Hanson. You can do a relay if that is okay. All right, so the first question, I'm just going to start off by this question from Mr. Williams, who says, what role will the registered physiotherapist play in these athletes with a positive test firstly? And is there a role for these clinicians on the RTP regime?
All right. The role of physical therapists, athletic trainers, and so forth in athletes who have tested positive with COVID and return to sport is critical and vital for them returning. All right, because in terms of hands-on, in terms of evaluating the athlete's whole musculoskeletal system, the flexibility, the muscle power, and so forth, and thing, that's a huge physical therapy that falls under physical therapy, and they will be able to determine whether one, this person needs to start off being in physical therapy with minimal weights and minimal stuff, or whether this person can head straight back to the gym and start a gym type exercise routine. So it is critical and vital to the return of these athletes that the physical therapists, the athletic trainers, and I throw the coaches in there, are involved in in assessing the athlete and their whole monitoring them, observing them, and determining how best to get them back to optimum physical condition and monitoring them over time.
Okay, maybe Dr. Hanson can answer the section on the RTP regime.
Well, I would just add that the physiotherapists are critical even before that in the critically ill patients, because they are the ones who also go into the isolation wards and start administering physiotherapy care from then. And, you know, they are part of the delivery of care throughout the whole spectrum of illness, right up to the point of rehab after in recovery and getting athletes back to where they need to be to perform. I searched the web for something similar to the algorithm I had for cardiovascular problems, looking for some similar guidance from the pulmonologist. And I really had a hard time finding anything about respiratory care after. Most of it is still, we're gathering evidence, we're gathering the data. So really they're being guided by prior experience with other conditions and people being in ICU for other conditions and applying those principles to the situation we have now. And I think that would further, in the next few years, we'll have a better idea of just how to get them more involved. But they are absolutely critical. There's no question about that.
Okay. All right, thank you so much. All right, so the next question is, okay, what is the importance of having a national blood profile of the Jamaican athlete who was infected for reference in case his or her blood profile has changed tremendously or could signal questions about doping?
David, you have spoken on the whole biological passport and so forth before. So you want to take this?
So you dropped a little bit. I didn't hear what you said.
Oh no, I was saying they're asking about the whole idea of blood profile and the blood profile changing. In other words, change the biological passport of the athlete. And I said, and I asked the question was about the importance of that. I mean, just briefly. I mean, you can talk more about it because I know you had you had presented this one, but the bottom line again is go on.
Yeah. So WADA has.
Yeah, go David.
So WADA has a database which stores the blood profile of elite athletes in for I think it is 10 years. So they keep a record of those results over a long period of time, such that there's any sudden change, they can always go back to what they have already garnered in previous tests and start comparing if they think the change that they are seeing is significant. So you know, in terms of liver function tests, and that is the whole idea of why Dr. Jones is saying you must always have documentation. If you've had COVID, you've had to be treated for it with any of these medications. You need to have documentation on hand to say, listen, I was treated with these things. This is what I was treated with. This may change my blood profile. Here's the explanation for it. Okay? I don't know if that is a question a person is asking.
I think that's pretty much what they were asking. Dr. Jones, adding anything else?
No, just to echo that. Again, whatever this extend beyond COVID or whatever, if you're ever treated for something that could alter your blood or whatever thing, just make sure that you have the relevant medical documentation by the treating physician to and to present it to JADCO, so that if you're an elite athlete being tested by the elite panel, which is would be the IWFL, World Athletics, then you present that to them, let them know, so that if by chance there's a change in your biological passport, you have legitimate justification for it as backed up by the evidence. So yeah, it's important that you have documentation for that and present it.
Okay, all right. So the next question is, I have heard recently that COVID-19 can cause costochondritis. Do you know this to be so?
All right, off the bat, no. Costochondritis, real ACE receptors in the secondary fibrocartilaginous joints of the ribs that meet your chest plate. So I haven't seen anything about that. It causes costochondritis. It might, but I haven't seen anything about it. That's based on basic principles. I don't see where we haven't had much evidence of COVID being associated with arthritis, causing general arthritis in any of your other joints, So costochondritis, I'm not familiar with it doing that. I mean, I don't know if the person was kind of a chest pain from it, but not costochondritis. I'm unfamiliar with it.
No, I haven't come across that. I mean, the only way I can see something close to that being made as a diagnosis is the coughing. Sometimes when you have this persistent coughing, the intercostal muscles become very painful, but that happens with even irregular flu or cough and cold. And I don't know if that may be mistaken for costochondritis. But I really haven't seen any of that in the literature either.
All right, then.
It might not be a direct cause and effect, but it might be as a result of the coughing caused by COVID. That ends up with costochondritis, but not COVID itself causing the costochondritis.
Yeah.
Okay, I am going to. Okay, so the next question is, wouldn't it be advisable to get ECG, lung function, or stress test done before returning to play, since COVID-19 is associated with endocarditis?
Well, myocarditis.
Myocarditis.
Well,
Yes, myocarditis.
we had said, if you if you have a major illness, so this would really be, I guess, for the patients who have not, athletes who have not had a major illness. And if you want to be safe, then sure, get all the relevant cardiac tests done, you know. However, for the lung, again, it's not that critical for lung function test unless you have had a history of a severe course of lung damage or lung illness during the course of the virus. Because like I said, the lung, losing some lung tissue is not detrimental. You know, your lungs will respond and will hyperinflate and will adjust to any loss of lung tissue by the virus. But the heart, on the other whole, is a different thing. So for those, again, for those who definitely had a cardiac event during the infection with the virus, definitely yes. But for those who have only had a mild course, it's debatable whether you're going to put them through the rigors of getting the COVID test done, getting all the various cardiac tests done. Remember, there's only one elite athlete who had a major cardiac event, and he technically had ethnic predisposition to the condition. You know, there was only one documented case of a sudden cardiac death from somebody who recovered from mild COVID symptoms.
Okay.
What I would go back to how I started my presentation when I made the definition of what an athlete is. Remember, it was a broad definition, and in that definition, we included the masters athletes, which can go anybody over age 35 who is a serious athlete. That population would have a higher incidence of predisposing conditions, underlying comorbidities that would put them at risk. And in fact, there was one person in Jamaica, I can't remember what his name or his occupation was, but he was on radio giving an outline of his whole experience. Based on what he said, he had moderate to severe COVID, but treated himself at home in the basement, had his pulse oximeter, blood pressure machine, thermometer, and all of this sort of thing. I remember him telling the story that he and two of his other friends all three of them were athletes in college and had remained active throughout their lives now that they were middle-aged or older. All three of them had COVID. He had it out here, they had it in Canada. They recovered, and he said that his two friends in Canada went out and started doing their regular exercise routine. One of them dropped dead from a heart attack and one dropped dead from a stroke, right? So I would say, thinking now broadly, not necessarily limiting ourselves to thinking about the elite athlete, but think about the masters athlete who have these other conditions. You'd have to take them case by case and decide which ones should be the ones to be subject to cardiac screening. And that would be my advice.
I see Jackie Beckford Henriquez, known as Jackie Beckford, Jackie commented in the chat that the person you're talking about, I think, was Robert Richards, who was Caribbean badminton champion. A guy I actually grew up with. He actually originated from Christiana's side before his father came to town to run Scotiabank here. But Robert was Caribbean champion and so forth, and he ended up with some significant sequelae after COVID, and he's played Masters badminton as well. You know, so I think that's what that's the person you're referring to, based on what Jack is saying.
Yeah.
Okay, all right. So then the next question I'd like to ask is, I guess this is in line with our high school athletes. The probability of overtraining is high in our adolescent athletes. One symptom is suppressed, I'm assuming suppressed immune system. I guess they may be talking about asymptomatic um, patients. What are the implications and the future for athletes who have contracted COVID-19 and is returning to sports where they are likely to be overtrained?
Uh, I think we kind of answered that. I mean, it's a gradual return regardless of the symptoms you had before. Do not bring the athlete back and then you give them this whole host of aerobic activity that's going to stress them, whether it's in the pool, whether it is on the field, in the weight room, or to do not bring them back and start them training as if they never had COVID. That is unwise, So, and the coaches have to recognize that and recognize that a lot of time coaches are trying to achieve results and they're forcing athletes to, you might have to group your athletes separately, have the post-COVID ones train separately at their own pace, and you gradually return to increase intensity as you activity as you go along. But overtraining on a whole is not recommended, it's bad. And then with a post-COVID athlete, it could be critical, meaning you could end up with the person dying, like the two former athletes in Canada, and this one elite young athlete, he was 27, basketball player who died in Serbia. Post-COVID, but they can't confirm that it is COVID myocarditis that happened. Just an association.
All right. The final question, and I guess this person is making an observation and asking us, do we agree that there's not enough of a prophylactic synergy between both sectors, such as coaches, trainers, I'm going to include doctors, physiotherapists, of athlete management outside sport post-injury?
I agree with that. I remember a few years ago, we had Glenn Mills present at our seminar that we had. And he started his presentation by begging us to work on this aspect of the development of our athletes. Because he was saying that many times by the time the athletes get to him, there is very little that he can do with them because they have accumulated so many mismanaged injuries over the years that him trying to make them world-class athletes from where they are at when he got them was almost impossible. We in the JASM have also tried repeatedly. We have tried to organize seminars. I remember one year we had seminars sponsored by one of the insurance companies and sent invitations out to coaches. We don't usually get very good support with these things. And, articles have been written in the paper about it and all of these sort of things. My personal feeling, if you look at places like the United Kingdom, Italy, and all of these other places, they have very strict laws and regulations governing the management of minors in sporting activities. And if you look at the academies, the football academies in the United Kingdom, depending on the age of the children or the teenagers in their programs, they have a prescribed amount of hours that these athletes train for, and how many matches they can play per week and all of these sort of things. And then that is backed up by social workers who monitor it. So I think that having tried all the other ways to improve this, Jamaica may have to go that route where, we we put in place certain rules and regulations that backed up by law to enforce some of these things.
Okay, noted.
Just backing up David on that. So yeah, we at the Sportsmen Association, we encourage and we try to offer assistance and information to anybody who is willing to hear us, you know, in terms of training regimes, athletes going back to sports, injury management, and so forth. Unfortunately, a lot of times, coaches have their own people who they see as giving them advice and athletes going back to training. Sometimes these persons are qualified, some of them they are part of the association, sometimes they are not. And we have had to intervene when they've come to us, and athletes who are either coming back from injury or whatever, who are not being properly managed based on best practices, and then advise them accordingly. And then on top of that note as well, in athletes that sometimes we're treating athletes and recommending certain things. Some athletes we have operated on or whatever, and they're supposed to follow a specific physical therapy regime before they get back to sport. And they disappear. They disappear from us, they disappear from the therapist. Next thing you know, we see them competing somewhere, and we never saw that they had reached back to that point. So the bottom line is, on all levels, we all need to communicate. And that's why the association consists of not just medical personnel, but coaches, physical education teachers, academic types, and otherwise. That's what the association consists of coming together of minds of all aspects of sport for the overall benefit to optimize sporting outcome.
All right. I think that is going to do it for the questions, as I don't want us to go too long. And so I'm going to hand over to Dr. Joan Rattery, who will do our closing remarks and vote of thanks.
Well, folks, I am sure you must agree with me that we've had a very informative session. And one of the things that we realize is that with COVID-19, we are still learning. Remember, it's the novel COVID virus. It's new, it changes, and information comes in bits and pieces, and we have to keep current. We have to keep informed, always listening, always following, and trying to learn what is happening out there. Unfortunately, there is good information and there's bad information. Today, our doctors, Dr. Hanson and Dr. Jones, have provided us with a lot of good quality, evidence-based information that has helped us to understand a lot about how the virus is transmitted, how it attaches itself, the fact that it can cause so many of our vital organs to malfunction, to not respond in the way that we would want them to respond once we have become victims of the COVID-19 virus. They have also provided us with guidelines. And one of the things that we must remember for our athletes who do get sick, who have contracted this virus or produced a positive result upon testing, is that return to play for them has to be a gradual thing. It is a very real thing when people have these the fatigue symptoms and the weakness and the brain fog and the mental stress. These things are real. And I'm gonna put a little note in here to say that I know this for sure because my husband, from August of last year, he contracted COVID-19, and to this day, he still is suffering from fatigue. it's hard to go past 4 hours, 5 hours of work because you do feel so tired, you just really just can't continue. So for our athletes and their training programs, this has to be a gradual process. Some will have mental issues because they may be afraid to get back out there and to train as hard because they're afraid that they will get sick again and they will not be able to manage to get back to that level of, to that top level, to where they were before they were sick. And we have to encourage them and provide them with all the support that they need in order to achieve this. It definitely has been informative. We've definitely had some good questions, and we are learning. We are constantly learning. And therefore, I'm really appreciative of the initiative from GC Foster, from physiotherapist Afneil Lamont, who approached me and asked for the Sports Medicine Association to collaborate with them. This has been a good activity. We've had a lot of participants. It went up to 146, I believe. And that shows that there are a lot of persons who have logged in, and I'm hoping that they will take the information that has been provided today and disseminate it and share it with others, and still question and try to seek answers so as to guide themselves going forward, and to use our protocols, to use the guides that the Ministry of Health has put out there. Because besides for everything else, the sanitation, the wearing of masks, and the distancing still remains the main things that we have to practice in order to keep ourselves safe. So we thank the GC Foster for providing this forum, for Mr. Cliff Allen, who has been the IT guy, who has done all the setup and the arrangements so that we could also be on YouTube, for our doctors, Dr. David Hanson and Dr. Gwyn Jones, for the principal of GC Foster, Maurice Wilson, and Vice Principal, Mr. Paul Beckford, for being here with us. And of course, Afneil, for being the instigator of all of this, and assisted by Desreen. So we thank you all. And we hope to be with you again at another event. Certainly the Sports Medicine Association will have our keeping pace sessions soon, and you will be informed. Thanks again for joining us, and have a good evening, everyone.
Yes, good evening, everyone. So we'll be sending the certificates for all the persons who would have registered later on in the weeks to come. And we will make the presentation available for those who might request that.
Quite a number of persons have been asking already. Thank you very much, ladies and gentlemen. Doctors,
Thank
you
you,
are all
sir.
the best. Mr.
Was
Allen,
good. Was good.
Dr. Rattery,
Yes, sir.
the inspire, the rose among the thorns.
Well, I don't know if I'm among, I definitely don't think I'm among thorns. They're
Yeah, okay.
definitely not.
The thorny issue.
Thanks. Again, thank you all, and all have a good evening to you all.
Thanks for having.
And,
Thanks.
we hope in the very near future we can collaborate again and make these things even bigger and better, because the requests are coming in. I was just seeing one chat where they were asking, how can we collaborate to have this thing where we could include the coaches now in some sessions as it relates to these issues. So we can talk off air and see if we can put things together and accommodate some of these coaches in another setting where we can now equip them to go out there and deal with their situations as they do their work.
Okay. It would have been we would have been blessed today as part of our session if Coach Gibbs was here, because then he could have thrown in that coach's perspective and made it a more rounded thing. So it wouldn't have just been from the medical side.
All right, so thanks again, and all being well, we'll meet again in the very near future.
All right.
All right, guys.
Good. Take care.